Hi, everybody. Welcome to another IG Live from the Fibroid Doc. This is going to be a really good one. I am just trying to get my guest on here. Let's see. Should be on any where you are watching from. Hi there.
Hello.
Hi. All right. Great. All right, everybody. So we have our guest on, Dr. Lisa Tharler, and I'm going to let her introduce herself in a second. But if you are watching this live, please say hi in the comments, and if you're watching this later, please type in hashtag replay. So we just ended Fibroid Awareness Month in July, and there's so many guests that I wanted to feature, and so I'm going to do that through August as well. And I had a really great conversation with our guest today, Dr. Tharler, maybe 3 weeks ago, and she's doing some really fascinating work and things that would really help, I think, patients as well as physicians. And so I wanted to bring her on, and I'm so excited to have her here. And so, hi, Dr. Tharler. Would love it if you could introduce yourself.
Yes, so I am Lisa Tharler. I am a full-time internal medicine, med-peds trained internal medicine hospitalist. And my passion, how I got re-energized and more efficient and more of a leader in the hospital system after COVID, was by becoming a trauma-informed embodiment coach. Working with physicians, working with my own patients, working with my own team in a very challenging population. I live in very rural Hawaii with very limited resources. And by learning about trauma, by learning about creating safety, by learning about emotional intelligence and really world-class communication skills, I'm able to bring that to my clinical work. And then I also coach and do classes and have a mastermind for women physicians, particularly because we straddle both of these places. You know, I think many physicians are post-COVID wondering, how do I still stay in medicine? How do I do it efficiently? How do I really enjoy it again? And some of the things that I'm able to teach that I learned that worked for me, that were super powerful, then translate into multiple clinical areas and then multiple areas of their own lives as well. So I'm so happy to
Great.
be.
Yeah, thank you. So you're a trauma embodiment coach, and that's what you said. So tell us a little bit more about like what, practically speaking, what does that mean? What kinds of things are you helping people with?
Yeah, so I have some women physicians that have their own trauma and other things personally, and so I work one-on-one and in groups with that. But I think for the purpose of this conversation, how I work with this with patients is going to be even more relevant and more important, especially when we're talking about fibroids, especially when we're talking about like the reproductive system of females.
Yes.
We know the statistics on sexual abuse and trauma, 1 in 3, 1.5 domestic abuse history of trauma and sexual abuse. And so that can feel really daunting and heavy and something to really put outside of the clinical scenario when you have 10 minutes to interact with a patient. It's like I think a lot of physicians feel like I don't want to go there. I don't want to open something that may, what am I going to do with that? I don't know how to handle that. And that may be very valid. So I would say if
Mhm.
this is an area of interest, come follow me, come learn more. There's ways to do it, but even more than that, you don't have to necessarily have that conversation. It may not be appropriate depending on your timing and your clinical scenario. But what we know about, and this comes from polyvagal theory, what we know about nervous system regulation is that we co-regulate with each other. So if I
Mhm.
walk into a clinical room and I'm anxious and I'm high anxiety, or I'm detached, I'm withdrawn, I'm not making eye contact, I'm not connecting, that the patient in front of me is going to co-regulate with my nervous system. And I may have a patient coming in for surgery who's very anxious, who's very detached, who can't make eye contact, history of trauma, maybe, maybe not, maybe just like, I don't even want to deal with this, right? Like, we all have those moments where it's like, really hard to connect with, build a relationship with. And so the beauty of this work is that by learning how to regulate your own nervous system by very simple exercises, like so simple, moving the eyes, some points in the ears, using really the pathway of the vagus nerve that goes down the face. By doing these exercises, we calm regulate our own nervous systems. And these are things that I'll do before I go into the room, because I want to make sure that my nervous system is calm and regulated, and that the patient is regulating to me.
Yeah. Yeah, no, that's so great. I think I read somewhere, I listened to this, where, when you're having a conversation with somebody, you often mimic each other, even in the posture. So if you cross your leg, they're crossing their leg. If you put your hand on your chin, they're doing that. And so I find it so fascinating. And I've seen that with patients as well. So the way we got started about this is, as a gynecologist myself and a minimally invasive surgeon, I do take care of a lot of patients with fibroids. And one of the common questions and concerns that comes up is when it comes around, treatment options and what should we do. So sometimes I've seen patients who are doing quite poorly in terms of kind of keeping up with the symptoms of their fibroids in terms of bleeding and anemia. And so they're rushing to the ER all the time to get blood transfusions, and they never can predict what's going to happen, and they can't go on vacations, and really it's a big issue. And so they've tried all the things, the medications and the shots and the pills, and finally they come to me and I said, well, if it's really so debilitating to you, I would consider a surgical option. And often they're done having their kids, they're in their late 40s. Why not a hysterectomy? We have really great methods now, minimally invasive, you go home the same day. Of course, surgery. It's not to be taken lightly, but in a patient who has gone through the whole treatment plan prior and is still struggling with this, this is something that I bring up, and a lot of patients will say, "Yeah, that's right. I've already done all these things. I want to stop this, get this out of me. Let's go." And then I have a handful of patients who really are resistant to it. And as a doctor, as a person, as a doctor, as a surgeon, I sometimes wonder, like, oh my goodness, like, I mean, sure, it's their choice, but I wonder why it is that they're really saying no. I mean, they really tried everything, but they're so resistant to surgery. And it's something that I have a hard time wrapping my mind around that. And so I know we had talked about this, so I'd love to hear from your perspective, what could it be that's going through that patient's mind, that yes, this is terrible for them, it's very it's inconveniencing them, it's debilitating, but still they will not do surgery.
Yeah. I think there's a few different ways to approach this. And the other way we connected, which I think is always beautiful, is, as doctors, we are doctors and we're also human. So I actually developed a huge fibroid. It was really interesting and humbling as an embodiment coach. Realized that, well, beginning of 2020, before COVID, I went to the OBGYN, and I don't remember anything on my physical exam that was alarming. And yet when 2022 came, like, I knew I had a huge fibroid. I could feel it up around my belly button. And I really couldn't tell you, working as a frontline doctor during COVID, I couldn't tell you exactly when it started. I couldn't tell you when it grew. COVID was a real deal. I worked in New York, low resources, all that stuff. And I decided, against my doctor, to try to just have a myomectomy, and it ended up being successful. But I remember the day of surgery, he was like, "Are you sure this is what you want? It's going to be a much longer surgery." It was 5.5 hours. They may grow back. And of course I said, if there's even a question, take my uterus out. If there's even a question of safety, if there's even a question of anything, but if we could just do the myomectomy, that was my preference, and that's what ended up happening. And I think with robotic surgery, I could speak from my perspective with it being my first surgery. Even though I had tiny scars, he's like, you had a lot of stitching on the inside. I'm 10, and this was my first surgery, my first experience. I try to avoid the OR as a hospitalist, ICU doctor.
Sure.
I'm
Right.
coding, but this was like my first experience. So, I was I was that patient, and I remember being like, he is not happy with me. He is not making it home for dinner. It's a more involved surgery. It's a more involved recovery. He knows he may have to go back in there. It had grown large enough that I was sent to a gyne-onc. So in cancer, there was more of a risk. If I did it this way, more of a risk of needing. So it really was not. So what I want to speak to is that locating what the issue is with your patient. Sometimes we think we need to give more information, but we really make emotionally based decisions. So you give people more information, but if they're having a emotional response, you're really kind of wasting your time. I have this come up too, with my patients. I'm gonna wear my clinician hat. So I needed some information from my doctor. I needed his leadership. If he said, this isn't going to be successful, I don't, you have a high risk of bleeding, I wouldn't even try. I would have, you want to give your strong recommendation. If this is not patient-led, okay, you want a myomectomy, well, I guess I have to do it. No one wants that. I wanted his professional opinion on what the surgery would be and recovery, and I wanted that information. But after that, I really made an emotional decision. I wasn't sure if I was done having children. I didn't know. I had 3, and I never thought about it really until it came to, do I want my uterus taken out? And then all of a sudden I was like, I'm not sure.
That is such a good point, because, you're right. In the office, patients are like, I'm not really sure that I want a hysterectomy. And often, I've done this myself. I probably quoted statistics on, well, the recurrence rate is this and this and that. And as you said, I'm giving more information to the patient, but that's not necessarily what they want. They're completely looking at it from a different angle, and it's an emotional one. So the key is to tap into that and connect with your patient on that. Is that right?
Yeah.
Yeah.
And me, being I'll turn 40, it was really hard to say to a doctor, I have 3 healthy kids. I always kind of pictured another one. I'm not sure. And I'll be 40. And, then all of the, are you really going to go through, then your details of your sex life and your fertility and, all things, which I didn't necessarily need to have with him. He was wonderful and addressed those issues. He recommended I talk to IVF before making a decision, making sure that would work with me, to get all of their information, and all the lab work was done. And some of that was done by my, regular GYN. It was multiple conversations to get so that I could have all the information I needed to make a decision. And once I had someone that, if I wanted to, was willing to do IVF, and I knew my numbers and all of that, then we moved forward. But even that day of, he was like, are you sure?
Yeah.
Much harder, much longer. So I think the emotionality of the decision, not going into our heads as physicians, we tend, and really everybody, right? I just dropped my kids off at school. They'll learn everything in the brain. We don't learn a lot of emotional intelligence. We don't really learn to locate someone else's fear, someone else's grief, right? It's like, oh my God, if I take my uterus out and I realize that I'm never going to have children again, the grief and the sadness, we don't know what to do with that.
Yeah. We don't know. So you named them. I mean, the grief.
I'm not become counselors and emotional processors in the clinician room, but so what you want to do with patients is, 1, make them feel nervous system regulated, You're going to regulate your own nervous system. If you want to learn simple exercises, you could come follow me. If not, do your own mindfulness, like whatever you need to do to not be detached in the room.
Yeah.
Relate to each other the way we bonded to our early caregivers. This is smile, eye contact. So when you're seeing someone new, and a tone of voice, like kind of like my tone now. You don't want low tones. You don't, no loud noises. So you want to create this like eye contact, smiling. I'm on your side. I care about you. My voice is calming. This goes a long way. People's nervous systems are regulated. They can at least, if your nervous system's not regulated and you're like I'm going to have to fight with my doctor to get what I want, or I'm just going to get the information and get the heck out of there. I don't even want to deal. Someone's in fight or flight. They're not even processing what the heck you're saying. They don't have the cortex available to even understand you. So you have to do the nervous system work first, or locate them first. Then you can appeal to their frontal cortex, but you want to look at your patient. If you know that you're telling them things and they're disconnected, they're looking around the room, they start crying, like if they do something and you know you're giving information that's not landing, for the love of all, please stop. You're be frustrated with the visit. That's when at the very end they finally tell you what happens and you're like, crap, we're out of time.
Right.
Focus in. If they're following you, you give the information.
Yeah.
So maybe ask, do you need more information till you make your decision? How are you feeling about it? You can use that F word, that medicine out a little bit. How are you feeling about it?
Yeah. Yeah. So we said we labeled grief. I mean, yes, but the removing the uterus is so final, even though, you could be 40, you could be 45, you may know that, when you're 45, yes, you're probably not going to have another baby, and you probably never even wanted another baby, but still, it's the finality of that decision. What other factors could be influencing a patient's, they may not want to tell the physician, but there may be other things that are going on that, that are leading to this decision where they just don't want to do a hysterectomy, even though, you recommend that as their best option.
So one is like, are they just in some fight or flight?
Okay.
Getting some information from their primary care, doing a trauma would be amazing, but that could be a big ask. If they've had sexual or physical trauma, they might, that's like a whole area. But something in the back of your mind when people get really funny about decisions, because remember, we're talking about 1 in 3 and 1.5 women. So knowing that that's a possibility, with asking for consent, along the way, using language that's like, we're going to make this decision, empowering language. We're going to make this decision. Case. I don't see a rush here. If we did nothing and you continued, this is what it would look like. Letting them know that they're in charge and they're empowered of the pace. There's nothing immediate. Yeah. Truth. There's nothing immediate to this. I mean, I'm assuming you're in an office. You're not seeing them in the ED. They're not bleeding out, right?
Right. It's not an emergency, not life-threatening emergency.
Decision about your body. Asking for consent. So I'm saying if you don't even want to have the conversation about trauma, that's fine. Asking for consent before you touch them. Letting them know they're in charge of the pace and the speed. And then letting them know that you're going to help lead them through this decision with your medical expertise. And say, I'm going to treat you as I would my own family. And I'm going to give you my opinion because that's really what you're here for. And if I recommend, something strongly, I'm going to let you know why. And if I really am against something, I'm going to let you know why, because I want you to have the best medical expertise to make the best decision for you.
Yeah, that's great. The language is so important.
That I would use. Then the safety. Yeah. Bringing, is there grief? Potentially there could even be anger. The women in general don't express anger as well, but there could be some anger, right? Let's say you have a woman that has no children for many reasons. She was in a poor relationship. She was a professional and she feels like she waited too long. And now it's like, maybe other things have happened. And I'm like, this is my 5th surgery I've had to have in 2 years. I can't even believe that my body's doing this. There could be a lot of anger that went. own bodies. Let's be honest, females and their reproductive system and all the laws and everything going on. As women, we have a lot of reasons to be angry. So
Yeah.
anger could, and then there could be some fear, right? You're having surgery. Many women are the linchpins of their family. We're
Mm.
not great at building support systems. We tend to caretake to everybody else. And so I know for me, it was a real thing. You know, I live in a rural setting. I had to have 4 weeks off. When I told my boss, I cried. I was like, I'm so sorry. How am I going to be off for 4 weeks? Maybe it could be 2 with an abdominal binder. You know, taking off work, people can be, you know, I was lucky. I mean, financially as a doctor, I had a lot of privilege and freedom, but, you know, fear around the finances, fear around the support. I had 3 children, like who's going to take care of them? You know, am I going to
Yeah.
be, who's going to help me in the recovery time? There can be a lot
Yeah.
of that, truthfully, you know, I
Yeah.
couldn't, I mean, I have 3 kids. Like, what do you mean I can't lift more than 5 pounds for,
Yeah.
you know, 6 to
I
12
mean,
weeks?
these are real considerations that we have to think about. And
Yeah.
often the patient is has a list running through her mind, but to be honest, I feel like sometimes our medical system does not allow us to really have these conversations because, you've got 15 to 20 minutes from the moment the patient walks in the door to the moment they leave, which leaves you maybe 10, 12 minutes to actually talk to the patient. Now, in my practice, prior to operating on somebody, I make sure I, have two or three, probably at least 3 conversations with them in detail. One just about the surgery, but the others about, the decision to have surgery and the factors around it. But just from this short conversation, there's things I should even be doing better. So that's so great that you've brought these points up. But what about patients who, have a 10-minute visit, they've got to make a decision and boom, they want to talk more, maybe they can make another appointment, but the next appointment is 4 months away. And this is, a real scenario that happens. What would you say to these patients? Like what would you say to the patients and what would you say to the physician? What couple of things could you do to get there faster, to reach that emotional state, to get really deep, to figure out what's really going on?
Yeah. So handouts are always really good for the technical aspects because that, you know, the technical aspects of the surgery can kind of be 1 year in, 1 year out. You know, having a handout that they can look at before, after, you know, call back with questions, that could really help so that you can really talk to. So doing that regulation beforehand, making a my tone, you're gonna how maybe taking less time with the facts by using some pre-made sheets, some teaching tools so that you can be more efficient.
Mm-hmm.
um, and then you're talking about a small, you know, following the patient, seeing, okay, they're following me, they're nodding, they're asking questions back, versus like, I lost
Right.
them to go, and I'm just still going, I'm still staying my shtick.
Yeah, your
And
script that you have in your mind.
you can have
Right.
a little out, like, why bother? You can, you know, have your nurse go over it after you leave, step by step, the instructions, and this is what she told you about, you know, how the surgery will go, all of that. And then saying, you know, we can go at your own pace. What other information do you need to make a decision? Is there
Right.
anything else to tell you about to make a decision? How do you feel about the surgery at this point?
Yeah, that's so good. There was a recent New York Times article just this week about medical gaslighting and about how so many women feel unheard. They were just said, "Oh, this is, part of normal aging. This is part of menopause. Oh, don't worry about it." Things like that. And so it's become really even more important to, I think, be prepared prior to seeing your physician. Okay, here are my goals, here are my questions, here's what I want answered. So you can bring that right up front, and then if the visit is too short, you can make
Yeah,
another appointment. So it's
yeah.
really important to advocate for yourself, I think, in that sense.
So I think physicians can probably pre-screen. You know, you could do
Mm,
a little questionnaire on, you know, what do you know about the surgery, 1 to 10? How ready are you to have surgery? What are your top 3 goals with having the surgery? And what are your top 3 concerns? Do you have any financial or other concerns about your support following the surgery. I mean, that could be a little thing that your nurses ask or the patient fills out. Super, super easy to do a little screen.
That is so good. That is so good because I mean, you don't have to have an hour-long conversation. I mean, the patient's telling you right there. And so
Yeah,
you can, in your
yeah,
conversation, just dial into those concerns.
yeah.
Yeah, that is
And
so good. Yeah.
as a patient, you know, in my scenario, there was, you know, the specialist. I mean, I live on Big Island. There's no specialist, so the
Hmm.
specialist had to come. He does one day in Queens little you know, clinic for the day. He flies in. He sees patients for pre-op. He flies back, and then you see him when you're ready in the OR.
Yeah.
Um, so, you know, it wasn't a long experience. It wasn't multiple. It was just that simple. So I think as a patient, you know, it's harder, but I think the kind of questions that I ask is, you know, what if I do nothing right? What if I do nothing? If I'm not ready to make a decision, like what if I do nothing? What do you think would be the best time frame?
Hmm.
Um, are there other options? What makes you think this is the best option?
Mm.
You know, those
Yeah.
kind of questions that lets me know how much uh and do I feel safe with this person? Do I think they're competent? Do I
Sure.
think they do good work? But honestly, you know, my surgeon was pretty informative.
Yeah.
Say that it was the most, but my OBGYN recommended him, said he was technically amazing.
Yeah.
And I, you know, there's something to be said for
Yeah.
being the best person on an island that's recommended by my OBGYN. You know, I
Yes.
was like, know that we need to be like best friends forever and you need to know everything
Right.
about, like, you need hands and take care of my
Right.
uterus. So,
Yes. Yes.
you know, that piece. Um, so, but I think if you're kind of doing more of that and more visits, you know, those are the questions I would ask as a patient. Like, is there an urgency to this? What are the other options that we didn't talk about? Um, and, you know, knowing the speed at which I have to make a decision
Sure.
and making sure that I've gotten all the options out there. And then,
Yeah.
you know, asking the person you're seeing, if I want to learn more about this, what resources do you recommend? The blank Google search, I mean, you can go down the rabbit hole, and then if you're not afraid and angry and sad when you started, you certainly will be as a patient by the end of it.
Yeah.
Most
Yeah.
doctors should know, you know, even if you're 40s and 50s, but like most doctors, we grew up with the internet. Like, we should know the good resources that we
Yes.
recommend look at, so that we know patients are going to look. We know all of this
Yes.
and really guide them instead of leaving them to go down weird rabbit holes. And then you have to
Yes.
answer odd questions and it
Yes.
just goes sorts of awry. I
And I,
think patients really want us to lead them more than we think. And we don't
yeah.
step into that. That's why I coach on leadership. Like, they really want us to be like, I know. How much better would that feel as a patient if your doctor says, we all look things up. I look things up. I'm going to give you, the reason you come to me is I'm an expert and I'm going to give you the best resources so that we can
Yeah.
have the best patient, as opposed to how it used to be, which is like, you dared to Google Doc? Oh,
Yeah. Right. Right.
worse for her. It's like,
I,
let's be, you have something in your own life, right? Like, your family
yeah.
asks you about X, Y, and Z because you're a doctor and you're like, I don't freaking know. That's not my
Yeah.
expertise. You
Right.
Google it and then you fine tune it, right? It's like, we do the same things. So I think
Right.
just honest and leaders in that area is super important.
Yeah, that's a good point. And a lot of physicians and surgeons, I mean, have their own resource, right? Like, I mean, I have my own Instagram channel, I have my own YouTube channel, and like that, ask your doctor, hey, do you have a social media presence? Because I know that sounds a little, maybe a little frowned upon, a little while ago, but not so true anymore. Because what better resource? I mean, if a patient is having a hysterectomy with me, the best thing that they could do is probably just go on my YouTube channel, the Fibroid Doc, and listen to my videos on hysterectomy that their surgeon, have put out there. So they're not just randomly looking at Google and going to different unknown sources. And so that's something that a lot of physicians are doing now. And so as a patient, look into that and see if they have more information, in their own words, a blog post, a video, a talk, whatever it is. And that would make me feel better, if I had to have a surgery and I just
Yeah.
went to my own surgeon's website, right?
Yeah.
So
The program.
that's a good one.
Still, there's still some doctors that are using social media, Facebook and Instagram for personal use.
Yeah.
Some that, depending on your employment, it can get really funny. You could feel like
Yes.
you're public about certain things. I don't know. It gets, everybody's different in
Yes.
how they feel on camera, but I mean, this is, this is my favorite thing to do is to get more women, more physicians,
Yeah.
sharing. I mean, this is what makes medicine fulfilling, right? When we can just
Yeah.
talk. We can
Yeah.
just talk
Exactly.
on the things that we want to and feel like we're educating, feel like we're being ourselves.
Right.
So so any physician that will be on social media, it lets us be human. It's like the best PR for the profession.
Yeah. Right.
Doing this in our spare time. And it's a great business and branding for who we are.
Yeah.
So I absolutely love all of it. Yeah.
Absolutely.
Yeah. I'm so
Great.
glad.
Well, yeah, no, it's been so much fun. And I just, refer a lot of my patients to my own videos. I'm like, oh, you have this question? I mean, here's a brief answer, but for in-depth, here, I have a video on it, and then they look at all my other videos and they're like, oh, great, now I understand this so much better. And so, yeah, it's a great resource. Um, well, I have learned so much in this half an hour, and I have immediate things that I'm going to that's okay. Hi. Um,
Okay.
changes. Hello. Changes that I'm going to make to my practice, for sure. And are there any last words of wisdom that you have? You shared about how you were a patient recently, underwent a myomectomy, which is a removal of a fibroid, and you are a physician as well. So, any last minute thoughts about that, being in kind of that dual role at that time, and anything that you learned that you may have otherwise not, you know, gleaned or
Mm,
kind of made aware of?
let me kind of tap in and think. Um, I think, I think, I think realizing that we're always both. There's been kind of this toxic culture in medicine where we must show up as expert all the time.
Yeah,
Professional is this cold, clinical, logical way, and I think that the way of that is so over.
yeah,
It worked for us. I don't think it works for most women physicians in particular. I'm not sure it works for most men at this point either, to be honest. I don't think it works for patients. Maybe it works for some administrator that just, gets us to move patients along a system. I truly don't know
yeah,
who at this point.
yeah,
Realizing that um, your patients want your medical leadership. They want your leadership. They want to know that you care. They want to know that you're expert, that you got them. I'm going to take,
mm-hmm,
I got you. I'm going to
yeah,
make sure all questions are answered. And like, I'm a human here. I
yeah,
want you to feel like how I would tell my family member is how I'm talking to you.
yeah, yeah.
It,
No, that's
with
so
that
good.
surgery too. So if you have concerns financially or how you're going to be supported, I've totally been there.
Yeah,
Don't have an exact, but in my line of work, many times I'm telling family members that someone in the hospital's older and they need more help at home, and the family looks
mm,
at me. I do that. I work. I have small kids, and
mm,
I don't go into my head and say, well, the statistics are that. I go into my heart. It's a learned skill, and I'm like, I totally get it. It's an unfair ask, and I've thought about it in my own life. I
mm,
work in a hospital 40 hours. I have 3 kids at home. If my mom needed 24-hour care, I've thought a lot about, like, how would I even do this?
mm,
And I have educational and financial privilege and opportunity. So I know this is, like, so ridiculously hard, but we're going to figure it out together, what might work best for you and your family.
yeah,
So I think being human, being able, we've been told that we have to show up as perfect as expert. Like, no one actually really wants that. They want our
yeah,
leader.
yeah,
They want experience.
yeah,
They want caring, and they want our connection, and they want us to build relationships. And we think that it takes so much more, that it's so much harder. The truth is, practicing medicine in your head where you're not connected to any of your patients, none of them know you, and you feel cut off from how you feel for the majority of your workday, that actually is much more draining, much more
Yeah.
of a burnout.
Yes.
The cost of that is actually really high, yet we
Yeah.
think that it's easier. It's
Yeah. It's not.
very
Yeah.
practicing medicine if it was still that. It
Yeah.
wouldn't be as interesting or enjoyable to me.
Yeah. No, that's such a good point. And this is where it's just not the science, it's the art of medicine, right? So much is in the art. It's being able to talk to a patient for 5 minutes and really drawing, what's really their concern. I mean, you have all the medical knowledge. We've gone to school for years and years and years, right? But really making that connection, and yeah, it just goes back to it's really both as a science, but more than that, I feel like it's an art. So this is a perfect example of that. Thank you so much for this conversation. Really, really enjoyed it. I know it took us a while to sync up from Hawaii time and PST and kids and summer and all of that. But this was so great, and I really appreciate your time. And I hope people will watch this and learn from it. So I know I learned a lot. So thank you
Yeah.
so much, and I hope you have a wonderful rest of the day.
Yeah.
And
Love it. Inspired me. I'm mostly on Facebook.
uh-huh.
Um, I will come on IG, and I'll have to have you on whatever is for me. But
Yes,
yeah,
yes,
this
definitely. And tell our viewers where they can find you.
yeah. So just my name, Lisa Tharler, is an easy way to find me. And then my brand is Under the White Coat MD. I work with everything that kind of brings us under the white coat: the trauma, the nervous system, the emotions, all of those kind of things, and how I walk it. As a working mom
Yeah,
of 3 kids in clinic, and helping inspire leadership for other women physicians. Because I want people to stay in medicine, and I want people to be the kind of doctors that I want to go to. I want to bring
yeah,
my mom. I want to bring my
yeah,
kids to.
yeah.
So this is a burning passion of mine.
That's great. Yeah, so follow her, folks, and you can also find me at the Fibroid Doc on YouTube, or www.thefibroiddoc.com. And thank you for watching, and have a great day. Oh,
Thank you.
all
Bye, everyone.
right. Bye. Bye.